Hello, I'm Professor Capron, and welcome to this presentation on ventricular tachycardia. Let's take a look at the learning objectives for this presentation. By the end of this presentation, you'll be able to understand the identification and ECG characteristics of ventricular tachycardia, comprehend the underlying physiology causing VT, recognize the assessment and presentation of VT in patients, learn the medical management strategies for VT, including emergency interventions, implement effective nursing management and interventions for patients with VT, and identify related conditions and risk factors associated with VT. These are the key terms for this presentation. Please pause the video and make sure you get all of these down. If you're struggling to understand any of these even after viewing the whole presentation, please come and see me in class. Let's take a look at the ECG characteristics of ventricular tachycardia. Ventricular tachycardia typically presents with a regular rhythm. This means that the intervals between each QRS complex are consistent, unlike in some other arrhythmias where the rhythm might be irregular. Consistency in rhythm helps to differentiate VT from other conditions like atrial fibrillation, which has an irregular rhythm. The heart rate in VT is significantly elevated, ranging from 100 to 250 beats per minute. This rapid rate is a result of the ventricles firing at a fast pace due to an abnormal focus within the ventricles. The high rate can severely reduce cardiac output because the heart doesn't have sufficient time to fill with blood between beats, leading to decreased perfusion to vital organs. In VT, the P waves, which represent atrial depolarization, are typically absent or not visible. This is because the abnormal ventricular focus overrides the normal sinus rhythm, leading to a lack of coordinated atrial activity. Without P waves, the atria are not effectively contributing to the cardiac cycle, further diminishing cardiac output. One of the hallmark features of VT on an ECG is the presence of wide QRS complexes. A normal QRS complex duration is less than 0.12 seconds. In VT, the QRS duration exceeds 0.12 seconds, often appearing broad and bizarre. This widening occurs because the ventricular depolarization is initiated from an ectopic focus within the ventricles, rather than following the normal conduction pathway through the AV node and bundle branches. The abnormal path lengthens the depolarization time, resulting in a wider QRS complex. VT can present in two different morphologies. In monomorphic VT, all QRS complexes have the same shape and size. This indicates that the abnormal electrical activity is originating from a single focus within the ventricles. In polymorphic VT, QRS complexes vary in shape and size. This suggests multiple foci or a more chaotic pattern of ventricular activation, often seen in more unstable and serious conditions like Torsades de Pointes. Now let's look closer into the physiology of ventricular tachycardia to understand why and how this arrhythmia occurs. VT is characterized by a rapid ventricular rate. This fast rate results from electrical impulses originating from an abnormal focus within the ventricles, rather than following the normal conduction pathway that starts from the sinoatrial node. These abnormal impulses cause the ventricles to contract rapidly and out of sync with the atria, leading to an inefficient pumping action and reduced cardiac output. There are two primary mechanisms that lead to VT: re-entry circuits and abnormal automaticity. A re-entry circuit occurs when an electrical impulse continues to travel in a loop within the heart tissue. This can happen when there is a block or delay in one part of the conduction pathway, allowing the impulse to re-enter and repeatedly stimulate the heart muscle. This looping impulse can cause the ventricles to contract prematurely and rapidly, leading to VT. Re-entry circuits are often seen in patients with scar tissue from previous myocardial infarctions or other forms of structural heart disease. Abnormal automaticity refers to the situation where ventricular cells spontaneously depolarize and generate electrical impulses independently of the normal pacemaking activity of the SA node. This abnormality can be caused by ischemic damage, electrolyte imbalances, or other pathological conditions that alter the electrical properties of the ventricular cells. These ectopic impulses disrupt the normal cardiac rhythm and lead to VT. VT is frequently linked to underlying structural heart issues or ischemic conditions. Post-myocardial infarction patients are at high risk for VT due to the presence of scar tissue in the heart. Scar tissue creates an environment conducive to re-entry circuits and can also disrupt the normal conduction pathways, leading to abnormal automaticity. Patients with heart failure often have dilated and weakened ventricular walls. This structural alteration can promote the development of re-entry circuits and increase the likelihood of abnormal automaticity. Acute or chronic ischemia, which is a reduced blood flow to the heart muscle, can lead to electrical instability in the ventricles. Ischemic heart tissue is more likely to exhibit abnormal automaticity and support re-entry circuits. Various forms of cardiomyopathy, such as hypertrophic or dilated cardiomyopathy, can alter the structure and function of the ventricles, predisposing them to VT. Now let's examine the critical aspects of assessing a patient with ventricular tachycardia. Accurate assessment is essential for timely intervention and management. Patients often report a sensation of rapid, forceful heartbeats or palpitations. These palpitations are typically felt in the chest, neck, or throat and can be quite alarming for the patient. Dizziness occurs due to a decrease in cardiac output caused by the rapid, inefficient contractions of the ventricles. This reduction in blood flow can impair cerebral perfusion, leading to lightheadedness or dizziness. Syncope or fainting may occur if the brain receives insufficient blood flow for an extended period. This is a serious symptom indicating a significant drop in cardiac output and requires immediate attention. Hemodynamic instability is characterized by significant changes in vital signs, such as hypotension and tachycardia. This instability can lead to shock if not promptly addressed. Continuous monitoring of blood pressure is crucial. VT can cause a significant drop in blood pressure due to decreased cardiac output. Hypotension is a sign of hemodynamic instability and can indicate that the patient is at risk of going into shock. Monitor the heart rate closely. In VT, the heart rate typically ranges from 100 to 250 beats per minute. A rapid heart rate can further compromise cardiac output and exacerbate symptoms. Be vigilant for signs of shock, which include cold, clammy skin, rapid, weak pulse, confusion or altered mental status, and decreased urine output. Shock is a medical emergency and requires immediate intervention. Continuous ECG monitoring is essential for confirming the diagnosis of VT and monitoring the rhythm. VT is characterized by regular rapid ventricular beats with wide QRS complexes. Look for the absence of P waves and the presence of monomorphic, that's uniform, or polymorphic, that's varying, QRS complexes. Monomorphic VT indicates a single abnormal electrical focus, while polymorphic VT indicates multiple foci or a more chaotic electrical activity. Regularly analyze rhythm strips to detect any changes in the pattern or rate of VT. Any transition from VT to a more unstable rhythm, such as ventricular fibrillation, should prompt immediate action. Document any episodes of VT, noting the duration, rate, and any associated symptoms the patient experiences during the episode. Rapid identification of VT and immediate intervention are critical. It can quickly deteriorate into ventricular fibrillation or cause significant hemodynamic compromise, leading to cardiac arrest. Communicate effectively with the patient to understand their symptoms and provide reassurance. Explain the importance of continuous monitoring and the steps being taken to manage the condition. Let's take a closer look at the medical management of ventricular tachycardia. Antiarrhythmic medications are used to control and convert VT to a normal rhythm. Common medications include amiodarone and lidocaine. Amiodarone is a potent antiarrhythmic that works by prolonging the action potential and refractory period in cardiac tissues. It is often administered intravenously in acute settings. Amiodarone can be given as a bolus, followed by a continuous infusion to maintain rhythm control. A typical order might be something like an initial bolus of 150 milligrams IV over 10 minutes, with a continuous infusion of 1 milligram per minute for the first 6 hours, followed by 0.5 milligrams per minute. You would need to monitor for potential side effects such as hypotension, bradycardia, and pulmonary toxicity. Regular ECG monitoring is necessary to assess the effectiveness and detect any adverse effects. Lidocaine is another antiarrhythmic used primarily as a second-line treatment for VT. It works by blocking sodium channels, which helps to stabilize the cardiac cell membrane and reduce excitability. A typical prescription you might see is an initial bolus of 1 to 1.5 milligrams per kilogram IV, a repeat bolus of 0.5 to 0.75 milligram per kilogram every 5 to 10 minutes as needed, up to a maximum of 3 milligrams per kilogram, and then a continuous infusion of 1 to 4 milligrams per minute. Watch for side effects such as central nervous system toxicity, including confusion, dizziness, and seizures. Continuous ECG monitoring is essential to evaluate the drug's effect on heart rhythm. Now, if we have pulseless VT, so we have VT on the monitor, but there is no pulse felt on the patient, we need to go to defibrillation. It is the primary treatment for patients with pulseless VT. It involves delivering an electrical shock to the heart to terminate the abnormal rhythm and restore a normal rhythm. Ensure that the defibrillator is in the correct mode for defibrillation, not synchronized cardioversion. Place the defibrillator pads on the patient's chest according to the device's instructions. Typically, you'll be delivering a shock of 200 joules, that's biphasic, or 360 joules if it's monophasic, as recommended by current resuscitation guidelines. Always follow your facility's protocols and procedures, which are likely to be based on the American Heart Association ACLS algorithm. Immediately resume CPR for 2 minutes after delivering the shock. Reassess the patient's rhythm and pulse after 2 minutes of CPR. If VT persists, deliver additional shocks and continue CPR as per the advanced cardiac life support protocols. Synchronized cardioversion is used for patients with VT who are hemodynamically stable, experiencing symptoms such as chest pain, palpitations, or dyspnea. Synchronized cardioversion delivers an electrical shock timed with the R wave of the QRS complex to avoid inducing ventricular fibrillation. Place the cardioversion pads on the patient's chest, set the defibrillator to synchronize mode, and select the appropriate energy level. Usually this is starting at 100 joules for biphasic or 200 joules for monophasic. Administer the shock and reassess the patient's rhythm and symptoms. We need to address underlying causes. So electrolyte imbalances, particularly hypokalemia and hypomagnesemia, can precipitate VT. Correcting these imbalances is essential for stabilizing the cardiac rhythm. So administer intravenous potassium chloride for hypokalemia or intravenous magnesium sulfate for hypomagnesemia. Regularly monitor serum electrolyte levels to ensure they return to and remain within normal ranges. Myocardial ischemia is a common cause of VT. Ensuring adequate perfusion to the heart and treating ischemia can help to prevent recurrence. Administer medications such as nitroglycerin to improve coronary blood flow. Consider revascularization procedures such as percutaneous coronary intervention, PCI, or coronary artery bypass grafting, CABG, if indicated. Continuous ECG monitoring is needed to detect ischemic changes, and you need to monitor cardiac biomarkers such as troponin to assess the extent of myocardial. Now let's look at nursing management for caring for patients with ventricular tachycardia. Upon recognizing VT, we need to quickly assess the patient's level of consciousness, airway, breathing, and circulation. Check for the presence of a pulse. If the patient is pulseless, initiate advanced cardiac life support protocols immediately. Evaluate the patient's hemodynamic status, including blood pressure, heart rate, respiratory rate, and oxygen saturation. Look for signs of hemodynamic instability such as hypotension, altered mental status, chest pain, shortness of breath, and any signs of shock. That would be cool, clammy skin, for example. We need to prepare for emergency interventions. If the patient is pulseless, defibrillation is the priority. Ensure that the defibrillator is readily available and functioning correctly. Position the defibrillator pads on the patient's chest according to the manufacturer's instructions. Please remember that you will most likely not be the staff member who is running this code situation. However, you do need to understand the steps that you are likely going to see. So we'll be delivering the appropriate shock energy, 200 joules biphasic or 300 joules monophasic, as per resuscitation guidelines. Immediately resume CPR for 2 minutes following the shock, then reassess the rhythm and pulse. For patients with stable VT who are symptomatic, so they're experiencing chest pain or severe palpitations, but they do have a Pulse. Prepare for synchronized cardioversion. Set the defibrillator to synchronized mode to ensure the shock is delivered during the R wave of the QRS complex. Administer sedatives or analgesics as prescribed to minimize discomfort during the procedure. Again, you're likely not going to be the person running this situation, but you do need to know what to expect. Follow the cardioversion procedure, starting with an energy level of 100 joules for biphasic or 200 joules for monophasic, and monitor the patient closely. Place the patient on continuous ECG monitoring to observe the cardiac rhythm closely. Identify and document any changes in the rhythm, especially the onset or termination of VT. Monitor for signs of other arrhythmias or complications, such as ventricular fibrillation. Frequently monitor vital signs, including blood pressure, heart rate, respiratory rate, and oxygen saturation. Record and report any significant changes or trends to the healthcare provider promptly. Maintain an accurate record of the patient's clinical status and any interventions performed. You're going to need to explain to the patient and their family what VT is, including its causes and potential complications. Use simple, non-medical language to ensure that they understand the seriousness of the condition and the need for immediate and ongoing treatment. Discuss the management plan, including the use of antiarrhythmic medications, the potential need for defibrillation or cardioversion, and the importance of addressing underlying causes. Provide information about lifestyle modifications that may help to reduce the risk of future VT episodes, such as avoiding caffeine, reducing stress, and adhering to prescribed medications. Inform the patient and family about the importance of follow-up appointments to monitor the patient's cardiac health, and encourage them to report any new worsening symptoms immediately. Now let's look at the related conditions and risk factors for ventricular tachycardia. A myocardial infarction, commonly known as a heart attack, can lead to the formation of scar tissue in the heart muscle. This scar tissue can disrupt the normal electrical pathways of the heart, creating areas where electrical signals can re-enter and cause abnormal rhythms. VT often occurs due to a re-entry circuit where the electrical impulse continuously loops through an area of the heart, leading to rapid ventricular contractions. Scar tissue from an MI provides the perfect substrate for such re-entry circuits, making MI a significant risk factor for VT. Heart failure is characterized by the heart's inability to pump blood effectively, leading to enlargement or dilation or weakening of the heart muscle. These changes can alter the electrical properties of the heart, making it more susceptible to arrhythmias, including VT. The structural and functional abnormalities in heart failure the stress on the heart, which can trigger abnormal electrical activity. This increased susceptibility makes heart failure patients more prone to developing VT. Potassium is critical for maintaining the electrical gradient across cardiac cell membranes. This is essential for normal heart rhythm. So hyperkalemia and hypokalemia can both lead to dangerous arrhythmias, including VT. Hyperkalemia can cause peak T waves and widened QRS complexes, while hypokalemia can lead to flattened T waves and the appearance of U waves, both of which can predispose to ventricular tachycardia. Magnesium plays a supportive role in cardiac electrophysiology, particularly in the regulation of calcium and potassium. So hypomagnesemia, low magnesium, can lead to prolonged QT intervals and predispose patients to arrhythmias like VT. Ensuring normal magnesium levels is crucial for preventing arrhythmias. Patients who have undergone cardiac surgery may have scar tissue or other structural changes in the heart, increasing their risk of VT. Surgical procedures such as valve replacements or coronary artery bypass grafting can alter the heart's electrical pathways. Conditions like hypertrophic cardiomyopathy, dilated cardiomyopathy, and congenital heart defects can create an environment conducive to structural abnormalities can interfere with the normal flow of electrical impulses, making the heart more prone to arrhythmias. Recognizing and understanding the risk factors for VT, such as myocardial infarction, heart failure, electrolyte imbalances, previous cardiac surgery, and structural heart disease, is crucial for effective prevention and management. Regular monitoring of patients with these risk factors is essential for early detection and intervention. Maintaining optimal levels of electrolytes, managing heart failure effectively, and addressing structural heart issues promptly can reduce the risk of VT and improve patient outcomes. Let's do a quick summary of what we've learned in this presentation. VT is characterized by a regular rhythm, This means that the QRS complexes occur at regular intervals, even though the heart rate is abnormally fast. The heart rate in VT typically ranges between 100 and 250 beats per minute. This rapid rate is a key identifier of VT. In VT, P waves are usually not visible. This is because the abnormal ventricular activity overshadows the atrial activity. The QRS complexes in VT are wide and bizarre looking, lasting longer than 0.12 seconds. This indicates that the electrical impulses are originating from the ventricles rather than following the normal conduction pathway. VT can be monomorphic, where all the QRS complexes look the same, or polymorphic, where they vary in shape. Remember that VT is caused by an ectopic focus in the ventricles, meaning that the electrical impulses start in the ventricles instead of in the atria. A common mechanism of VT is re-entry circuits, where the electrical impulse continuously loops within a certain area of the ventricles, causing rapid and repetitive depolarization. VT is often associated with structural damage to the heart, such as scar tissue from a myocardial infarction or ischemia, which is reduced blood flow to the heart muscle. VT can lead to significant hemodynamic instability, including hypotension, loss of consciousness, and even cardiac arrest if not promptly managed. VT can quickly deteriorate into more severe arrhythmias, such as ventricular fibrillation, which is life-threatening and requires immediate attention. Rapid identification and treatment of VT are crucial to prevent complications and ensure patient safety. Medical interventions include antiarrhythmics such as amiodarone or lidocaine, defibrillation if the patient is pulseless, cardioversion for patients who are stable but symptomatic, and the need to address any underlying causes such as correcting electrolyte imbalances, managing ischemia, and treating other underlying conditions. This is critical for preventing recurrence. Nursing intervention involves immediate assessment, preparing for emergency interventions, continuous monitoring, and education of the patient and the family. Thank you guys for paying close attention to this presentation. Please remember, you need to go do something for yourself, at least for a few minutes every day. I don't want you getting burned out already. Remember, I'm very proud of each of you. Now get out of here and go do some nursey things.